join me in welcoming the MEC of the Western Cape Department of Health, Dr. Nomafrench Mbombo.
Thank you for the invite. And I wasn't sure exactly what could be the opening speech for the people who are coming from the technology side. Because if it was about only clinical, at least I don't have to do the PowerPoint. So I was just doing the PowerPoint for also my sake, because it's not necessarily my area. But I'll just take not more than 10 minutes around that. It's just to show in terms of what is happening in the Western Cape, not only to talk about the general aspect of it, and also to locate the importance of the information systems, the technology within the broader health system. So I'll move quickly. I'm not going to even look there in that area. Firstly, we need to understand that we locate it in terms of, for governments, their responsibility is to render health services. But health is everybody's business. And it's our responsibility to strengthen the health systems, because health is made up of different systems, as according to the World Health Organization, it talks about the building blocks. In terms of the building blocks, these 6 building blocks, which is the leadership and governance, financing, medicines and technology, information, the human resource, and also the issues of service delivery. And these all, they embedded within the issue of the coverage, the access, the quality and safety. But whatever happens, it all is all about the people which is the people where we have to render the service. So it's the health priority that dictates organizational priorities. And these health priorities are for the sake of the people. So for today, in terms of the systems, we are talking about these two. Again, I want to repeat that it's strengthening the systems. Health is made of different systems as there. And we've got the Healthcare 2030. I know that was where I put it here because we're going to discuss also the NHI, because people might ask now, what is the Western Cape kind of the policy imperative when it comes to Healthcare 2030? Briefly, whatever you do, you have got this external environment that you have to look at, and it's an ongoing changes, as for example, the burden of disease, socioeconomic status, the budget constraints, and all of those. So you don't build any system that is out of, that is not within, is not responsive to the external environment. And also for us, of course, when we strengthen the health system, we're influenced, as according to 2030, the person-centered approach, where you have to look at these pillars related to person-centered, because whatever system you build, whether technology or information, it must be where it talks, it empowers also the patient, it's person-centered. Also for the person to be able to use informed decision to change his or her behavior. Also, issues around the integration, I'll speak about it later. And for us, we take the person, that people was in the center, for the whole of the life course, which is from unborn up to the oldest. So therefore, we follow that the person we have to consider, especially when we talk about the unique patient identifier. And then the issue of the continuity of care, we're not only focusing on the protocol level of care, but also starting from at the community level, at the zero family level, up to the tertiary level or central hospital level in terms of continuity of care. And this is based on, this is our vision that we're looking at, as I made an example in terms of that we must be responsible, the motivate population to take responsibility, we need to be world class. Of course, we're not talking about equivalent to Singapore when it comes to technology, but we are getting there. Our values, innovation has been added as part of it's a Western Cape government values, all the governments. Innovation is part of it. For example, the Department of the Premier even has the Directorate of the Innovation, which also assists in terms of other departments, if need be, in terms of the economies of scale for some of the other interventions. In health, when we talk about the support services, which is supporting the whole systems, we find that the issue of the technology, the issue of the information systems and all of those is part of the support systems. And we all want to achieve the health outcomes, as we see there, and also the issue of the service delivery. Again, when we talk about the systems and technology, there are those corporate governance issues related to the supply chain, related to the infrastructure, the pharmaceutical, and all of those. Then there are those that are related to the clinical governance. And therefore, for us, the integration must be both. So you don't talk about either or. So it's about that. At the end, it's all about the patient. Now, we are not a country on our own. We are the province, which is, in terms of the constitution, we've got concurrent functions with the national. And what is it that's happening in the national that we also responding to? As you all know about the 2012 e-health strategy that was introduced. It has expired now, 2012, 2016. Already, when it was introduced, we were far advanced in terms of some of the other aspects, in terms of strengthening the health system through information and technology. Also, we are also, what we do, we also are responsive to the national core standards related to the normative standard framework for the systems. And then also, because we have been far advanced, already they are piggybacking on what we already have been doing. For example, the interface between the Clinicom. Clinicom is a system that is used in the primary health care. The issues related, for example, to the patient unique identifier, and also using the Sinjani, which is aligned to the national database and the district health information system. Sinjani is a system which is mostly like in the city of Cape Town, where the health facilities are also under the local government. Just an example of some of the other issues where the initiatives we are working on together, piggybacking on other, because I'm going to speak more about them. Now, although we might have been advanced, but there have been some challenges, especially related to the IT, where it didn't follow it. It was not systematic, it was piecemeal, and also different, lot of databases, a lot of sources, a lot of vendors, each and everyone creating own system and then piggybacking and all of those. Also, there was no coherent vision, because one might come up with, I've got a brilliant idea, and probably maybe a vendor will say, I've got a brilliant idea, don't want to buy in, and then end up having a lot of the layers and layers of the system. And meaning that if you want to clean one system, it will impact on all others, because they don't talk to one another. And also, because we've got a 2030 health policy, as I've mentioned, that needs a transformation, we have to talk to the implementation of that healthcare 2030. And because already we have the unique patient identifier, we have to capitalize around that. And the issue of prioritizing IT, but within the context of health service delivery. The issue of the manual administration, especially at the health facility level, using the manual, and also have to strengthen the IT governance. As I indicated earlier, that with other systems, you talk about the clinical governance and corporate governance, but within the IT, it was mostly around the organizational and only corporate, not necessarily the aspect of the clinical governance. Of course, the network infrastructure, which needs to be being updated. This is the kind of the vision. I don't want to focus much on it because I want to give examples. Of course, the principles, which is I'm also urging whoever wants to develop or going forward, especially towards the implementation of the NHI, whatever it happens, that the principle is that it must add value to the patient care, and it must address health service priorities, because it doesn't, then it's useless for us as the service provider, as the people who have to render the health services. It has to improve health outcomes. I'll show you an example of some of the health outcomes that we've put in the system as a pilot, just to see how we can be able to track those. Of course, 2030, and also needs to a support by the internal client. Internal client is specifically the line manager, because what is the use of all the head office? We come up with all of those, but within at the facility level, the line manager there is unable to, yet is the person who's supposed to collect the data, for example, a patient data, and must also operate, as I made an example, with the current policies within the national level, and also encourage innovation, because you don't want to do things and then after that you scrap them and then you restart and all of those. So it must be adjustable and interoperable, so that when there's a need for innovation. So these are kind of strategic initiatives, but I want to make an example, probably let me mention now, and then when I show you the examples, I just go instead of focusing too much on it, because not all of you are clinicians. The strategic initiative, roll out basic systems. Basic systems already, as I made an example of what is the national, is piggybacking on us because we are far advanced. For example, the primary healthcare, PHCIC, the primary healthcare information system, the PACS, which is the patient archive system for the radiology. It's one of those. Sorry, the JAC, which is related to the pharmaceutical, because we're the first to introduce the chronic dispensing unit and also tracking of such for the systems in terms of the dispensing. These are existing, but they are not necessarily rolled out completely to all other areas. I'm just making an example. And these are the clinical-based ones. And the ones that are more corporate is the issue of the e-learning for the staff, the issue of the leave system, that is electronic, for example. And then for the digitalized selected priority processes, I'm going to show you what do we mean about that. We have got about 5 kind of the areas. Automation of frontline data collection and other clinical and corporate priorities. For example, you know that at the front line, people focus too much on the compliance of the whole of the manual instead of focusing on the actual rendering of the healthcare. Therefore, we have to reduce and shift the task from those on the front line. The integrated data system, as I made an example, that we've got a lot of those. Hence, we've got the provincial health data center now, where all these data can be all put together. IT at the point of care, as I made an example of the line manager, because it doesn't have to wait there, it must start from now in terms of collecting of the data, and then address corporate IT system priorities. These are the enablers, the leadership and management, which is currently, previously, in terms of the cabinet approval 2009, some of the IT functions have been centralized for the sake of the economies of scale, like from the Department of the Premier, and within departments they will have their sub-directorates related to that. And then in order to give support the business environment for the whole government so that the systems can talk to one another. But currently now with the IT vision that we have, it has been located to us, especially because we have to track some of the issues related to the health outcomes. Build technical capacity. You still, with the system, with the IT strategy that we have, it means that you have to employ more of the business analysts, you have to employ more of some of the technical staff and all of those, but also in terms of also at this various level, not only at the project management level, but also at the senior management level. Of course, the maintenance and support and innovation. I just want quickly to show some of the examples. This is a kind of a data center. We won't be able to see it, but I'm just to show you how complex it is, what we already have in related to the business initiative and environment. For example, when I say that you must talk to the health priorities, when we engage citizens and communities, like the catch and match, which is it's a way use of community health workers. They collect data through the cell phones related to maternal and child health in certain areas, pilot areas. And that data it goes immediately to the health facility or to the clinicians so that the patients can be matched to, especially if the person has been in the system, can be able to be matched and see that, oh, this one was delivered and whatever, with a malnutrition and with whatever, therefore needs a point of referral. Also, you have to improve access to existing services as part of that. As I made an example, for example, that we even now trying to match with the social development so that if need be for the social grant, if the child is due for the social grant, it's part of all of those. And integrated client-centered model of community-based care. Again, I made an example of what the national has asked us to do in terms of the integration or piggybacking on our existing system. So these are kind of the catch and match where it's being tested in the 3 pilot areas, and these are the community health workers who are using the phone. So we're enhancing them in terms of the work they supposed to do. It's not about a vendor or someone who collects the data. It's themselves as part of healthcare service delivery. Just in an example, some of the other examples when I made in terms of the patient viewing, this is the kind of the data that you have when you view in terms of the patient identifier, in terms of the integrated model. As you can see there, you can be able to see in terms of the health conditions, especially the HIV, AIDS, the ARVs, the child health related to the first 1,000 days. They are already within the system. You can be able to track. The bed occupancy rate, which is busy with, is part of the things that we are busy with. I don't want to put too much, like just making an example now of the tracking the patient from antenatal care for the first 1,000 days. So every person born, every child that is born, you can be able to track even up to, hopefully, by the time probably she or he retires. Because you use a unique patient identifier and also you have got all the data. And this makes it possible for, especially for those patients who have been identified as high risk, like the babies with the malnutrition, you could be able. Someone mentioned about it coming from the diabetes. This could also be linked to diagnostic, related groups where different disciplines, where you could be able to track the occurrence or the prevalence of, let's say, the cataracts or amputation and link up to the person when was diagnosed of the diabetes, even over the time. So this is the kind of the tracking of the patients within facilities. Also the tracking related to the EMS. Yes, with the EMS, for example, I've made an example of the diabetes in terms of the outcomes, the patient steps. Other thing, what is crucial is that I made an example that it mustn't be only the view, must be only at whatever level, at the district health information only, but at the patient view. So that's why we have got that unique patient identifier we can track throughout in terms of the condition. Also the facility management view, where we have got the dashboard for the facility manager with the sum of the metrics like the child health outcomes or morbidities and all of those. Who are the users? Again, we have to empower everyone related to the clinicians, the nurses, the primary users, secondary users, and also the researchers, because it's very important. And it makes it easier. Whoever is asking for information, data from us for the Western Cape government, you don't get it in the different corners. It's all collected into one. So where are we now? We are in the first part of the rollout of the basic systems, as I made in an example. And the second part is about where we want now to have new systems. For example, with the provincial health data center, it's in the private iCloud, where all of these multi-data are being collected, sources are being integrated so that to be able to be one. And also in terms of the applications, because at the end it must empower the patient, so it mustn't be only the catch and match community health workers to use the mobile tech, but also other levels of the healthcare providers. And then the third part, which is we are still far around it in terms of the corporate priorities, which is I made an example of. So in conclusion, when we talk about strengthening the health system, you are talking about the complexity of the systems, which is the information system, the technology system. They have become part of the whole of the building blocks. And you have to do at the input level, at the process level, and then towards achieving the health outcomes. And it must be embedded in a rich culture of the data management, because you need the data, and every data must be something that is more, that can be used, because it mustn't be collected for the sake of compliance or because you want to a clean audit and all of those. And also caution is not to digest inefficient processes, because digitize inefficient processes, because what is the use of that? Things are not working, but you want to use digitization and all of those in order to make it work, yet it doesn't even work. Also in relation to the corporate IT systems, that needs require further attention, and we have to set the priorities around the IT despite of the budget constraints. Therefore, that's why it must be part of the planning. So you don't only go late that, we have to go back. So when like in my budget speech 27, I had the whole section of the e-vision and the 60 million allocated to such. Just like as I had a conversation or the priorities is set related to the clinical and all of those. So it mustn't be something that is an add-on. It must be part of something that is mainstream. I think that's where we are. Thank you.
Thank you so much.